Okay, guys, shall I start?
Please.
Before, I know we're recording here. It feels weird. I feel like a Martian here. I haven't met many of you, and you haven't met me, and we're going to be dealing with each other very closely for the years of your fellowship. My name is Ramon Sandin. I'm a pathologist and the medical director of microbiology and virology at Moffitt. I work extremely closely with Dr. Green, who is my biggest friend at Moffitt, and we've been dealing with each other for a decade. We've been there more than 10 years. He's the ID chief, and I'm the micropathologist, so we interact almost daily. And you're going to be doing a short rotation, your short microbiology lab rotation with us at Moffitt. So we really look forward to having you, and the techs love the ID fellows, because we get from you some clinical correlation, you get from us the laboratory workup, and it's a perfect marriage. Everything then makes a lot more sense. And just last night, as we were talking, just very briefly, 4:45, I'm running out to pick up my child in daycare. Dr. Ring calls, Ramon, I need help. John, my wife can't go pick her up today, so I gotta go. Okay, no, very quick. It's just this guy with a long histories in ICU with a lobectomy and rheumatoid arthritis and all these big complications. And I said, okay, cut to the chase. There was a lobectomy, and the pathologist who read it out says there are some yeast there. Can you tell me what that is? He said, okay, I'll request the slides. The secretary quickly brings them. I look at the case and I say, oh boy. Background is fibrocaseous granulomatous. Fibrosis, caseation necrosis, multiple granulomas. This is the finding now. Loaded with these young, empty spherules and multiple old, distorted spherules. This is very consistent with an old Coccidioidoma. They were not really yeasts, they were spherules. And it's not the typical diagnosis that a 5-year-old can make when you see huge spherules with endospores in all stages of development. I mean, anyone can call that. But when it's an old thing like this that has reactivated, been there for a long time, in the midst of a lot of inflammation, and none of that ever grows, it's harder, because when you see old things like that, but very, very consistent. So that's the kind of stuff that we see there almost on a weekly basis. And I usually talk for several topics to you every year, but there's very little time, so this year they gave me 1 hour. And I said, let's keep it to what you will see mostly at Moffitt, more than anywhere else, fungi. Because of the bone marrow transplantation, the period of neutropenia, that's important for the molds and yeast. And then on the other hand, rule in or rule out cancers for coin lesions that end up being non-cancerous and then an infectious nature. Okay, so without further ado, let's get moving. You have the handout. My slides are usually self-explanatory with a lot of pictures. So, medical and diagnostic mycology of importance to the practicing physician. I usually have a little subtitle. Is there a fungus among us? Let's see if I can take this out of here. So that's me again, Ramon Sandin, medical director of microbiology and virology at Moffitt. And I give you their phone, fax, and email. And I'm very accessible. If I can help you in any way, please go ahead and contact me. The scheme that will follow in this talk, which I give as a board review course to the pathology residents who are going to be taking their boards the following week as a 3-hour course. This here is a 50 minutes, so we're really just touching on the very basics of the fungi in what time allows us. So we start with a few general considerations in identifying fungi, and then I jump to the comprehensive list, where I give you all of the mycoses broken down into their agents and into according to the extent of involvement or body site affected. Then we will take some of the selected more important agents individually, and we'll deal with a little bit of their pathology, their microbiology, and a few clinical pearls. Let's start with our overview. You may all know this is a review. Fungi are eukaryotes. And when we're speaking morphologically, they can be divided into two basic groups. the yeasts and the molds. Yeasts are unicellular, they're budding fungi, and they reproduce by either sexual or asexual means. When they're growing on a plate, the colonies are usually described by terms such as slimy or mucoid, and you'll see that today. On the other hand, molds are filamentous fungi. They grow by forming long chains of cells that we call hyphae. A mass of those hyphae is called a mycelium, and when those guys are growing on a culture plate, they look different, and the terms that we use are most commonly downy, fluffy, granular, and particularly cottony or woolly. Now, some very important fungi, like the one I just mentioned a few minutes ago, are dimorphic or diphasic because they have two faces. They have a mycelial or filamentous form, which is a free-living form in nature. That's how it grows in nature. We call that the saprophytic form. That is also the way it grows in the laboratory at room temperature. Room temperature and 30 degrees is the same thing. When we culture fungi at room temperature, we really put the incubator at 30 degrees, and it gives us this filamentous form. These guys switch over to a yeast or yeast-like, in the prior case that's spherical-like, parasitic, quote-unquote, phase, which is what we find when it's growing at 37 degrees on the plate versus 30, or since our bodies are at 37, that's what we see in histopathology, in the pathology slide. Since the form switch is in most of these occurs exclusively in response to changes in temperature, we call them thermodimorphic. And these are the agents that you're going to remember as the most important dimorphic fungi. They're pretty much all of them. There are 7. The first 4 are your deeper systemic pathogens. Terms of endearment are Histoplasmosis and Paracoccidioidomycosis. The 4 deeper systemics are dimorphic. 2 of your subcutaneous mycoses are dimorphic: Sporotrichosis and the black molds that produce Chromoblastomycosis. And then this very rare agent, a mold called Penicillium marineffi, described in the 1990s in the AIDS epidemic in Southeast Asia, particularly Thailand, because it happens to be dimorphic, very rare. Penicillia are not. And then it produces this beautiful red, burgundy wine-colored pigment that diffuses, and you have it right there. And that's usually a board question in either path or ID. And that's Penicillium marineffi. I've seen very few in my life in this part of the world, maybe 1 or 2, and some of them in proficiency testing surveys that they send us. But you gotta be aware that it's one of those 7 dimorphics. Okay, I gotta move on. Fungi are gonna be classified according to the extent of involvement of the body into 4 types, so that we can put every fungus that you will see as an attending in ID in one of these 4 categories, and they are superficial and cutaneous mycoses, the subcutaneous mycoses, the deep or systemic, and the opportunistics. We'll define those in due time. I'm done with part 1. We're moving to part 2, which is your big list. This is the list of all the mycoses broken down into those 4 types. And they are, and this is your laundry list. Number 1, the deeper systemic mycosis that can affect just about any part of the body and go systemically. And they're the 4 dimorphics that I already mentioned amongst those 7. Histoplasmosis, Blastomycosis, Coccidioidomycosis, and Paracoccidioidomycosis, referred familiarly as Histoplasmosis and Paracoccidioidomycosis. And we'll deal with them individually. This is a laundry list, so you can place all the agents into the 4 categories. Category number 2 is the subcutaneous mycoses. Traditionally, 5 of them. And I'll tell you they're no longer 5, and I'll get to that momentarily. These things are rare. You don't see too many of them. And amongst those, these last 2 are even more rare. So, the first subcu mycosis is mycetoma, which we call true fungal mycetoma when we're dealing with fungi, eumycotic mycetoma. There's a whole bunch of agents that cause it. Most of them are black molds. The one you're going to remember is this one, Pseudoalescheria bovidii. The first one, the more common cause in this hemisphere. Number 2 is chromomycosis or chromoblastomycosis, also caused by black molds. And we'll get to it momentarily. And the third one is sporotrichosis, caused by Sporotrichosis. The last two are extremely rare. Rhinosporidiosis, which happens to no longer be a fungus. About 3 years ago, it was reclassified as an aquatic protystant parasite. Just like pneumocystis was sent into the fungal realm, Rhinosporidium was now sent from fungi into the parasite realm. The agent is Rhinosporidium C. eberii. And the last one that occurs in dolphins and in selected parts of Brazil and Colombia, is lobomycosis by Loboa loboi, which the genus is now called Lacasia loboi. And these are very rare. I've seen just one rhino in my life and one lobo, and someone who came up from Belo Horizonte, Brazil, and that's it. And some of these you do see, but they're still relatively uncommon. The third of the 4 types of mycoses are the cutaneous and superficial mycoses. And there are 3 common diseases included there, and a whole smattering of tiny little ones that are mostly of importance to practicing dermatologists, really. The first 3 are candidiasis. You may wonder, why is Candida not placed amongst the opportunists when it is an opportunist? You really have to have an underlying debilitation. Well, most of the original books decided that since most of the manifestations clinically are of skin and mucocutaneous membranes, that Candida then should be left here. And you can do either. I just follow this particular scheme. Albicans is still the species most common in the world, but as we'll see, there's many others, many particular that are important to us because they're resistant to diflucan. Second one is Tinea versicolor. The agent is Malassezia furfur. And the last one is the Cutaneous or ringworms, called dermatophytosis. And there are species within 3 genera: Microsporum, Epidermophyton, and Trichophyton. Everything there is really of cosmetic importance. This is something called Tinea nigra palmaris or plantaris, just dark spots in the palm or plant of the feet, and it's called by Phaeoanellomyces, earlier Exophyella wernicki. These little concretions or piedras are called white piedra because it's white, or black piedra because it's dark. Their concretions usually occur in the hair of the axilla or in the pubic area, and mostly in people with bad hygiene or very, very poor people. I did my medical school at the University of Michigan in Ann Arbor. We rotated through the outskirts of Detroit, a big city of the United States. It is pitiful the amount of poverty we saw in some of those county hospitals. I can't name how many kids I saw with piedras when we were pediatrics or dermatology. So you do see a lot of these things in some populations, and then in other parts of the world that are disadvantaged. And then some additional rare mycosis and even some achlorophyllous algae like chlorella are included here for lack of a better place. And then moving on, this is where the money is for someone practicing in Tampa. Florida is warm and moist. If you're at Tampa, you have HIV. If you're at the VA, you have very old people. I'm very sick. If you're at Moffitt, you have the BMT patients. So that's where the molds are going to go wild. The opportunistic mycoses are divided into 4 types, and they are the Cryptococcosis by Cryptococcus neoformans. And then the more important ones and more frequent ones, and we see so many of them at Moffitt, the light-colored filamentous molds, Hyalohyphomycosis. And there's at least 100 genera, if not more, and thousands of species. The most important one and most common one is Aspergillosis and all of its cousins. The next group is the black molds, also known as demariaceous molds, Phaeohyphomycosis or black filamentous molds. And there are hundreds of genera of black molds. The last one is the Zygomycosis fungi that we see in people with diabetic ketoacidosis. We see it in people on deferoxamine therapy, iron overload. And there's species of the genera Rhizopus, Mucor, and Absidia as the most important in the United States, but there's at least 20 or 30 more genera. So those are your 4 opportunistic mycoses. And we have given you just about every fungus that you will have to identify clinically and that I will have to identify in the wet lab or in pathology. And everything is there, broken up into 4 categories. So for the rest of the 45 minutes or 40 minutes that we have, we'll take the more important agents one by one, and I'll give you a little bit of the pathology, of the microbiology, and clinical pearls with a lot of pictures, because that tells most of the story. Let's start with the 4 deeper systemic mycoses. Let's start with histo. You're going to remember from histo, beautiful little birdies and a nice little bat. It's present in the guano, meaning the dung or the feces and debris from birds and bats. Doesn't necessarily kill any of those, but it likes the nitrogenous products there, and it grows avidly. So spelunkers or cave explorers, where there's a lot of bats there, they can go in and take a good sniff of a couple million spores in the air from the aerosolization of the stuff in the poop of those bats, and they can get very, very sick. Thankfully, like in most of these deeper systemics, the great majority of people are going to have very subclinical or benign disease, usually in flu-like syndrome. But there's a minority of cases where they go on into the chronic illness, which is usually pulmonary or mucocutaneous or rarely systemic. There we also have, and many times in pediatrics, some rare acute fulminating cases of histoplasmosis. This is disseminated to an area of the tongue. This guy has a histolesion in the lip, and this is an HIV patient from Tampa General many years ago with a sinus tract that was cultured and biopsy proven histoplasmosis. While he had it in the intestine, I produced a sinus tract to the skin from that part of the body. Histo is dimorphic. When I say histo at 30 or histo at 37, is the histo in the filamentous form and histo in the form that we see in the body. Okay? Histo at 30 is worth remembering for the boards, and when it is worth, I put these gyrating little stars. Yes, wow. Lunch special. We have salad and we have Histo at 30 produces these very large spores that we call tuberculated macroconidia, which are very large spores that have these spines. That's how it grows at 30 on the plate. That's how it grows in nature. When we switch it over on the plate, or you get it in your patients, and I look at it in pathology at 37, the colony will switch from the mole-like colony to the typical 37-degree dry, what they call coral-like, looks like coral, or cerebriform because of all these waves. When we do a smear from that, it's totally different and very pathognomonic. Small budding yeasts, 2 to 4 micron, with a thin neck between mother and daughter yeast. This is pathognomonic for histo at 37. There's really nothing else in the realm of infectious disease pathology that looks like this. 2 to 4 micron, thin neck between mother and daughter yeast, 37 in the body, histo.
The first one at 37 is in solid agar, right?
Yeah, that's the agar plate. Correct, yes. We call it. In tissue, it produces granulomas that we call histoplasmomas. We put an oma at the end of the name of the guy. Coccidioidomycosis is what I called the guy last night. Histoplasmoma, Blastomycoma, Paracoccidioidomycosis. Okay. Old histoplasmomas are the typical fibrocaseous, like Cocci of last night, fibrosis, caseation, necrosis, or fibrocalcific fibrosis and calcification lesions. And there, the yeasts are dead or dying, and my attempt to grow them in micro is almost always unsuccessful. These things are old, they're sick, they're dying, they won't grow. Not the case in acute disease, where you'll see it in the cells of the reticulum endothelial system as intracellular budding yeasts, 2 to 4 microns, with a thin neck, just like I told you, at 37 in culture. So all histoplasmomas with abundant calcification, and in acute disease, intracellular yeasts. In a touch prep from bone marrow here, a few more in another touch prep, a cluster of them here, and this is peripheral blood. This is a huge monocyte. It's about 20 of those little yeasts. So again, intracellular yeast frequent in acute disease, not in chronic disease. I am moving on to blasto. A few things about blasto. Like all of these guys, oh, by the way, how do we catch the deeper systemic fungal pathogens? All of them. Same mechanism. You breathe in, the filamentous form. So it is very common that we'll get, most commonly, samples from the respiratory tract for culture. And primary disease here is pulmonary, like in all of them, but this one loves skin. It's also very, very dermatotropic. So you'll see a lot of chronic skin and bone involvement. Remember the eastern 1/3 or such of the United States. Other parts of the world also have it. Skin lesions can be very verrucous, like a bad seborrheic keratitis or even a squamous cell carcinoma. This is Dr. John Rippon's book, one of the classic ones in medical mycology, and one of the original pictures of someone with disseminated blastomycosis. Blasto at 30. No gyrating star. This is not pathognomonic. It's a fluffy mold, and it produces, when we look at it microscopically, these little pear-shaped or piriform spores. They're called lollipops, but they're not pathognomonic because Pseudoalischeria and several other saprophytes can have that too. So it's important to know it, but that alone will not give you the diagnosis, but this will. You switch it at 37. Or if all we have is tissue, okay? Nothing else in infectious diseases looks like this, just like I said for histo. This is blasto, 37 growing on the plate, dry, coral-like, cerebriform colony. When you do your smear from it, or when a histopathology slide is looked at, this is what you'll see. Huge mother yeast, of average 16 microns, with thick, what they call double contoured walls. Look how thick. And very broad-based budding between mother and daughter yeast. Very broad-based budding between mother and daughter yeast. Average is 16, but they could be a lot larger than that. Histo, 2 to 4 microns, thin neck between mother and daughter yeast. Blasto, huge, 16 microns, thick walls, broad-based budding between mother and daughter yeast. Moving on to cocci. That's the one from last night. You're going to remember southwest of the U.S., Sonora Valley of Mexico. The Sonora desert life is very dry, and it's a lot of salinity in the sand, and it just loves to grow there. It can grow in other places like southern Brazil and Uruguay and a lot of Argentina. Desert sands, inhalation of infected sand or dust as a person goes through with the windows open in a dust storm, you get a lot of it, and you get what's called a valley fever, that original flu-like syndrome. The majority of people are either flu-like syndrome or just asymptomatic, thankfully, like in all of these systemics. But there's always a minority that it can develop into dissemination, systemic disease. And when it does, like blasto, it loves skin and bone. Residual lesions in the lung, we call them coccidioidomas. A guy with disseminated cocci to the skin of the face, to the wrist, that involved very, very inflammatory. It involved the bone, and this one has a lytic lesion in bone. Again, skin and bone. Cocci at 30 has a migrating or rotating little star, pathognomonic. Cocci at 30 on the plate is this very nonchalant, fluffy white mold, like so many in the air. But you know what? In microbiology, we never sniff plates that have mold. You can sniff plates with bacteria, but anything that looks moldy, the text automatically shrink seal it. They put a little seal that dries, and it shrinks the plate. So they're closed, and you work with it on the bench, closed, or under the hood. You don't smell anything. What could happen if that nonchalant little white fluffy mold, like so many in the air, were cocci, and clearly that's not this part of the world, it's more in the southwest, you could get a good sniff and get a couple 100,000 spores and get your very, very sick acute disease. So this guy, this very infectious guy, when you do your smear in lactophenol cotton blue, this is what you see. Memorize this. This is pathognomonic. Barrel-shaped arthroconidia with the dead cells in between. And those are the dead cells that release the arthroconidia into the air, and that's why it's so infectious when people go through a storm in the desert, okay? Barrel-shaped arthroconidia with dead cells in between. That is cocci at 30. How about at 37? Cocci at 37. That's the one I mentioned, the case from last night. 37. Thick-walled spherules, average 50 microns, loaded with endospores in the mature case. But we're going to look for all stages of development in acute lesions. And in old coccidioidomas, you may just see fragmented spherules in old lesions. This was a case many years ago from Tampa Lleno, in fact. And I asked for the slides and 2 pictures. This is a young man, Filipino, went to visit his family in the southwest, came back with a whopping pneumonia that was coccidioidal pneumonia. He was HIV positive. It was his first presenting HIV infection. And he had all stages of development, including the mature ones, and some of them ready to release the endospores. When you have that, that's an easy call. Not the one from last night, where all I saw was broken up spherules, very distorted, and a whole bunch of young spherules, younger than these, many of them empty. So you know that this thing is very old, and it's just reactivating, breaking down, if you will, because the guy is immunocompromised. And that nice granuloma that is encasing that forever starts to break down, and that's where some symptoms may occur. Moving on to paracocci, a rare one. I've only seen a couple cases in my life. South American blastomycosis, very dermatotropic or mucocutaneous surfaces like the uvula, and this is all from Brazil. Disseminated to skin, looks like leishmaniasis in that part of the world. Also, an extremely inflammatory in this patient from Belo Horizonte in Brazil. And then lastly, this is the typical paracocci at 30, a mold. At 37, the yeast, the dry coral-like. But you're going to remember, it's pathognomonic. It's large mother yeasts with multiple daughter yeasts. Look at that, almost 20 or 30. Connected by narrow necks. Look at this one. Narrow neck between mother and daughter yeast. This has 4, this is up to 20. This is called the mariner's wheel, pilot's wheel, or ship's steering wheel. And that's the way to remember it for your boys. Paracocci at 37, pathognomonic. So histo, 2 to 4 microns, thin neck. Blasto, 16 microns, thick walls, broad base bud. Cocci, 50 microns, spherules with endospores. Paracocci, huge, 16 to 20, with the many daughter yeast connected by little necks. I gotta move on to the subcutaneous mycoses, which are 5. And in the interest of time in this abbreviated lecture, I'm sacrificing lobo because it's so rare. Rhino is no longer a fungus. It's an aquatic protystem parasite. I will have to sacrifice that too. And then just say a few words about these 3. In the future, if you want the whole lecture, I can do it. It will take 2 hours. It's impossible to do in 50 minutes. Okay, mycetoma. Observed in the early 1900s in Madura, India, called Madura foot or Maduramycosis, presenting clinically to you as a trilogy, usually a swollen lesion, usually an extremity, most commonly leg, with these draining sinuses, and there's going to be grains or granules microscopically that drain through that. This is a guy from Ecuador that worked with a lot of hay, and he got inoculated, and he had his mycetoma in the upper extremity, which is a lot more rare. Clinical trial, this is a woman who came to Moffitt many years ago, had a right below the knee amputation. This was a useless extremity. She was pulling, and it was indolent. It didn't hurt. There's no nerves anymore. And this was the specimen for pathology, the triad, when we cut it with a saw. This is all suppurative inflammation, pus, and just necrosis, fibrosis. So there was really no parenchyma there anymore. It's been there for many, many years. Two types of mycetomas for your practice, and they are actinomycotic mycetoma and eumycotic mycetoma. The actinomycotic are by the members of the actinomycetales, or higher bacteria, and the or true fungal mycetoma are the true fungi. The more common in the world are the actinomycotic. In the interest of time, there's many agents that can cause it. The most common one, just remember, nocardia. The true fungal mycetoma are usually caused by molds, most commonly, although not always, black molds. Many agents the one to remember is Suralischeria bovidii. Eumycotic mycetoma in the granules will have true fungal hyphae, whereas the actinomycotic mycetoma will have mats of thin filaments, 1 micron, because they're bacteria. I just threw this in yesterday for completeness. There's something that some people confuse with actinomycotic mycetoma. You will hear the term in your practice, Botryomycosis, from the term botrytis in Latin for bunch of grapes. This is really bacterial pseudomycosis, sometimes confused with actinomycotic mycetoma because it may look just like what I showed you, but it is caused by bacteria, not filamentous bacteria, but rather usually Staph aureus and Pseudomonas, rarely other gram-positive or gram-negatives. It's usually localized, although in rare cases it can go through the blood and produce hematogenous spread, and you'll see these lesions in other organs. That's all I can say about Botrytis. The second of the three important subcues is this chromo for color, because it's black molds, colored demariaceous molds that cause it. Demariaceous soil saprophytes, they go in via abrasions. By the way, you catch all the deeper systemics by breathing in the filamentous form. You catch your subcues by inoculation into the skin of the free form in nature with a thorn or a stake or something like that. Okay? And that's how these guys come in. These guys, black molds, instead of producing a swollen externate from inside, like a mycetoma, produce these cauliflower-like verrucous lesions that projects mostly outside. It is caused by black molds. The one to remember is the genus Fonseca, which is the most common genus amongst many others. And in tissues, I told you this is one of those 7 dimorphics. Histoplasmosis, Paracoccidioidomycosis. The chromo agents, Sporo and Penicillium marnefi. The agents of chromo, which are these black molds that we grow beautifully on the plate with fruiting bodies, switch when they infect the tissue. And they're called sclerotic bodies, corporate penis, or medullary bodies. Beautiful. And these are very large brown cells. They have their own endogenous coloration. This is not a special stain. That's how they come. They're yellow, brownish, thick-walled with several cells with this very irregular, what we call planate or irregular type of cell division. These copper pennies or sclerotic bodies are the 37-degree phase of the agents of chromo. Moving on to the last one that I'll cover, the subcues, Sporo. Sporo, for all they talk about, the Rose Gardner's disease, I've seen very few in my life. I'm from Puerto Rico originally, and we did see some, but not even too many. So I think they've blown out this guy out of proportion. It's not that important. Sporotrichosis by Sporotrich schenkii. Again, cutaneous inoculation by a thorn. They call it the Rose Gardner's disease, where there's an original lesion that spreads centripetally and produces then buboes, sometimes along the lymphatics. Original lesion, bubo, along the lymphatics. And it can be very, very inflammatory. And thus they call that lymphocutaneous sporotrichosis. Just like we can have lymphocutaneous nocardiosis. Very similar in looks sometimes. Sporo is produced by one of those 7 dimorphics. It is a black mold, demariaceous. The 2 forms is at 30 degrees of flower-like form, and at 37 degree changes to a yeast that's very long. We call that, this is the term you're going to remember clinically, cigar bodies. Cigar bodies. And those are the pictures. Sporo, black mold, reverse, also colored, and at 30 degrees, you see the little florets. And then at 37, the pasty yeast, and you do a smear in this very elongated and thin, up to 10 microns, yeast called cigar bodies. We're done with the first two of the four types of mycosis. The third of the four is the cutaneous and superficial mycosis, with three important diseases being candidiasis, tinea versicolor, which is really mostly superficial and rarely fatal, and I'll tell you when that happens. And then the last one is the teneas, the ringworms, called dermatophytosis. Let's start with candidiasis. Pearl. Everything we're talking about in these 50 minutes comes from outside. All fungi come from outside except Candida. It's an endogenous member of the microbiota, indigenous microbiota of our GI tract, GU tract, and skin. So most times we get it from ourselves when we become immunocompromised. That's why I said Candida is really an opportunist. Should I put it on the opportunist next time? Because then it comes from within when it's allowed to, because the defenses of the body are low. It produces many things, and you've seen them, you'll see more. Oral thrush, vaginitis, this is thrush here, diaper rash in children. It's one of the causes of nail infection, onychomycosis by Candida, onychomycosis by the dermatophytes, and at Moffitt, board question, the most common cause of nail and toenail infection in bone marrow transplant patients is Fusarium, which is just a mole, which loves nails in people who are very immunocompromised. Okay, and then rarely from the books, because I've never seen a case, chronic mucocutaneous candidiasis in children usually that have some sort of aberration of the immune system, chronic granulomatous disease, and then it produces horns which are loaded with the yeast and granulomas, but they don't eat it up, they don't digest it, so they don't get rid of it because of their underlying problem. Okay. Many species of the genus Candida. Worldwide, the most prevalent still albicans. However, in this country, throughout the 90s and beyond, we started realizing that we have problems with three other ones at a point where they were much more prevalent than albicans in fungemia in my patients at Moffitt. We did a study. Albicans was 4. The first 3 were Glabrata cruzi and tropicalis. Guess why? Because they're resistant to diflucan. We were using diflucan like crazy in the 90s. Then came the other azoles and stuff. They may have changed. I don't know. I'm going to do a study and see how much better has it gotten. I'm sure it's gotten better. But it's amazing to Dr. Green and I that we looked at all fungemias for 5 or 6 years. And before diflucan, it was albicans and the other ones. After and during diflucan, it was 1, 2, 3, and then 4 albicans. So keep in mind, agents that are resistant to a particular drug that you use, you're basically enriching for them when you use it. One last pearl. In tissue, when Candida is invasive, meaning it's not just saprophytically living there, you'll see the 3 forms, which are budding yeasts, hyphae, which are less common, and then the very common pseudohypha, with a pinching in between the elongated yeasts. The sausage link, if you will. Tinea versicolor, pityriasis by the agent Malassezia furfur. Used to be called Pityrosporum orbiculare, Pityrosporum ovale in the old days. Produces this is tinea, macules, papules, patches or plaques that could be hypo or hyperpigmented. In cancer patients, we've seen a couple of BMTs during the period of neutropenia with folliculitis like this lady here. I have a beautiful case, no time to present it to you. Rare, but I saw that early on in my residency. One of the very first cases I had to deal with was a 28-day-old baby who came to autopsy, who was a preemie at 7 months and had disseminated Malassezia. We didn't know that, but he had a catheter and he was getting intralipid through it. Perfect setup. And he got fungemia and death. Usually in patients on IV lipid therapy, I'll tell you why now, on a central catheter that allows the bug in the skin to make it in through, okay? The problem is that this is a lipophilic yeast. It requires an exogenous source of fatty acids. If you're giving the patient the intralipid, that's a perfect source. These are small budding yeast, 2 to 5 microns, And you're going to remember this to tell you apart from histo, which was thin neck between mother and daughter yeast. This is broad base between mother and daughter yeast. And it's hard to tell, but look at this right here. It's a broad base between the mother and the daughter yeast. These are small, 2 to 4, 2 to 5 microns. And Malassezia doesn't produce what histo produces. We never produce fibrocaceous lesions in lung disseminated like that. I mean, it just doesn't do that. It's a lot less virulent than that other agent. But if you had to tell in terms of different diagnosis, those are the two that look alike in terms of size, but they don't look alike in terms of how they connect to the mother yeast. Okay?
It's smaller than blasto.
Oh, blasto is 16. Okay. This is 2 to 5 microns. The third and last one of these superficial ones that we'll cover is the Cutaneous. Ringworms, dermatophytes. They affect anything with keratin, hair, skin, and nails. Ringworms are these circinet borders. You've seen them, very scaly, sometimes very itchy, with a growing border there that we do a scraping and we can look at it under a microscope. Produced by species within 3 genera: Microsporum, Epidermophyton, and Trichophyton. I don't think you need to know much more than that for the ID board. The pathology board, since they have to identify this, and proficiency testing surveys have them, and I go into it. I'll just tell you that the Microsporum species all have very large spores called macroconidia that are multicellular. The Trichophyton species have microconidia that we use for identification. And the more common cause of jock itch, Tinea cruris, eflocosum, produces these large macroconidia that are not spiny, and they have a round tip. So they look like the tail of a beaver tail-like Epidermophyton flocosum. That's all I can tell you in the interest of time. And I'm moving on to the last and the fourth and last. The mycosis most important for your practice in Florida are the opportunists. Cryptococcosis, which really you have to have a debilitation to have it. And if you don't think so, look closely in your patient. There's got to be some problem there. Hyalomycosis, light color most fail. Hypomycosis, mariasis or blacks, and the Zygomycosis. Remember, diabetic ketoacidosis, iron overload. Okay, crypto. Little pigeons again. Change color. Yeast. So it's with pigeon droppings. Again, it doesn't kill the pigeon, but it loves the nitrogenous material in the dropping. Also, a chicken and turkey. Most common manifestations that they'll present to you are these two, CNS and skin. And clearly, dissemination is possible, and host immunocompromise is present. This is a lady with leukemia, a brittle diabetic with disseminated crypto, horrendous involvement of the skin. This is disseminated crypto in one of our bone marrow transplant patients. This is from a book, the subacute or chronic meningitis, with a very wet look to the area under the meninges because of the capsules of these agents. What little I can tell you in little time on micro that you must remember is that these are budding yeasts that have huge polysaccharide capsules, and they have cells that are attached by a narrow thread, and there is huge variability in size and shape. Remember this as the most variable in size and shape of all the yeast in infectious yeast pathology. It's crypto, 2 to 20 microns. As tiny as 2, as big as 20. The colonies are mucoid, and they may slide down the plate, and they stain, the capsule stains with mucicarmine, pink-red. This is a very mucoid colony. You can tilt it, and it does slide down. This is an India ink, microscopically a yeast with a very large capsule that you can see there against the India ink. This is a disseminated case of cryptococcosis in a beautiful glomerulus with a mucicarmine, where the capsule is staining red, pink, and opposing itself to the top of the wall of the organism. 2 and 3 of the 4 opportunities are the moles. They're called filamentous moles, light colored or black. The filamentous moles that are light colored, like all of these guys, are free living in nature, in soil, And you can have the entire spectrum of disease, if you're disseminated disease also, in cases of our patients, which are usually all immunocompromised. Microscopically, remember Aspergillus as your prototype and all of its cousins. They're all under here. They're light colored, meaning they're going to be red or green or yellow or everything except black. And the only exception is Aspergillus niger, which is thrown amongst the Aspergilli, amongst the Hyalos, although it's a black mold. Spores are black. But every other Hyalo is light colored. Light color means not black, not demariaceous, not melanin containing. Okay? They love to invade blood vessels. This is a case of Aspergillus terreus, the beautiful blue-green colonies on a plate microscopically. This is a conidiophore, it's the name of it, with a vesicle, and the rows of conidia that project. And a picture from a slide culture is called, I love terreus, because it maintains itself when we do a Scotch tape mount or a slide culture for pictures. Very picture perfect. And the rows of conidia just emanating from the beautiful, large, roundish vesicle. The black molds or phaeohyphons, again, free living in nature, can cause the entire spectrum. The difference is pigmented, brown to black, because they have a melanin-like pigmentation. This is one of the ones we fear, and Dr. Green doesn't like it when I tell him we have a pseudosporiasis. Pseudosporum prolificans inflatum was the case here. 39-year-old woman with breast cancer came to autopsy everywhere, and any of the organs cultured, black mold, young colony, and the old one, after a few days, it develops a very strong black coloration, infarct in the brain, in the spleen, and in the kidney. The kidney has this beautiful hemorrhagic infarct here. Let me show you microscopic here, glomerulus. Glomerulus with a PAS stain shows a lot of the conidia and a lot of the hyphae. The last one, the Zygomycosis fungi, members of the order Mucorales. They're free living in nature. They grow in anything, shoes, walls in all houses, bread, all that stuff. You're going to remember rhinocerebral mucormycosis, and you're not going to forget it because I have something to show you. But also pulmonary GI, we've seen a couple of GI, remember that GI case? And dissemination. Predisposing conditions, diabetic ketoacidosis, we all know that for the boards, burns, and iron overload and diffraxamine therapy. From a book, early infection coming out into the skin around the nose, and very quickly, within 8 hours, it just necrotizes it, very vaso-invasive. General Rhizopus mucor and absidia, in tissue broad, ribbon-like hyphae, not like Aspergillus and its cousins. Those are regular, branch at 45, a lot of cross walls or septations, not here. Broad, ribbon-like, very few cross walls or septations. They sometimes fold like ribbons, okay? And when they branch at right angles, at 90 degrees. Extremely vaso-invasive. Last two cases. Lady from our practice, diabetic ketoacidosis, and she has another neoplasia, and then lo and behold, culture and biopsy proven involvement of the left cheek by mucor. So the family, in consultation with ID and the surgeon, agreed to a prophylactic orbital exenteration to impede the growth on the passage through the eye and the optic nerve into the brain, or through the nose and cribriform plate into the brain. Because once in the brain, Dr. Green can do nothing for these people. She did have a left orbital exenteration prophylactically, the ear here. This is nose. Eye and soft tissue centopathology. We do our sections and we see broad, hyposeptated, no septations there, ribbon-like. They call that moose antler-like, and that's how it looks, like the antlers of a moose. But microscopically all over the place except in the optic nerve. Couldn't find it, at least in the section submitted. She was packed. Unfortunately, starts to convulse very shortly after that, for reasons that I don't understand. The family says, go back Okay, let's go back. This is her a month later. Being prep for a craniotomy done, sampling, sent to pathology, and lo and behold, it's there. It's in the brain. This is a cross-section like that coming my way. Cross-section inside multinuclear giant cell, longitudinal sections that again look ribbon-like and broad. I did see one little area of 2 cross walls, which is very rare. And I took a picture so you know this is not aseptated, this is hyposeptated. She was clipped and she died. Shortly after that, it was planted. We shrink seal all fungal plates because if it's a mucor, which is the fastest growing fungus genus, this woolly thing will grow overnight. And if you're coming in the morning, the lids of the plates are pushed up. So these things are shrunk sealed on purpose. This was the next morning. I mean, this thing just goes wild. I'll get to it in a minute. Microscopically, this produces sporangiophores instead of the conidiophores they call the hyalohyphomycetes. Sporangium, and the spores inside are called sporangiospores instead of conidiospores for the other ones. Yes, I'm sorry. Okay. My last case, this is from the internet, and I thought it was interesting enough. We'll cover it in just 5 minutes. And this patient was in Larry King Live about 4 or 5 years ago. This guy was treated at the University of Louisville for facial deformity due to rhinocerebral mucormycosis that completely disfigured him. The problem is that, as far as I can tell, and I went back to the internet to find, they can't find exactly what prompted this, because this is a young man, healthy, not diabetic, who wakes up on a Sunday morning with a sinus headache. And the wife is the one that gave the information that by Monday morning it was so intense that his speech was incoherent. She just rushed him to the hospital. Clearly they did some smears and the diagnosis was made of broad, hyposeptated, ribbon-like hyphae, and very consistent with mucormycosis. This thing was so speedy that it invaded and destroyed the face and eyes within a few days. And this is him normally, and this is what happened. Basically, he had to have a surgery that included bilateral orbital exenterations, both eyes, the nose and the palate, the upper palate, upper jaw, including the upper teeth. 11 surgeries. So Ramon's in a coma, a very skilled maxillofacial prosthodontist from that university. My hat's off to him. He said, I have children too, and this guy had young children. We need to help cosmetically. So he said, I'm going to do what I've never done. I'm going to try to produce a very complex prosthesis. He made it in clay, then in acrylic, and then covered it with silicone that at least would, cosmesis-wise, would be better, and it would keep that area from getting a lot of more junk and more infections. And this is what happened. While I was giving this as a course in pathology at the Osler, there's this little voice in the in the audience. It was 5 years ago. A lady says, Dr. Sandin, my name is, of course, you name everybody who gives you things. Sumba Rami. Says, yes, ma'am. I was a first-year resident in that case at Louisville.
Wow.
And I said, do you have pictures of at least a little of the pathology? And she said, yeah, send it to me. Because I couldn't get that through the internet. I got the clinical picture I'll show you. So she sent me a few. This is the specimen sent to pathology. Unbelievable. And low power views of the H&E, hyphae there, and of a GMS. And then lastly, a side view. How is this deficit going to be covered? The plan is that the maxillofacial prosthodontist will create this prosthesis that will have magnets in the back as a surgeon implants these titanium rods into the bone with these magnets. So the magnets on the back of the prosthesis will hook onto the magnets that are protruding from these rods placed into the bone. That's him. He's being measured for the implantation of the rods. And now the rods are in place, and these little things are the magnets. More measurements, And this is the prosthodontist. He's measuring for his mask. And he did it in clay and then switched it to acrylic. I have no idea how. More measurements. He put hair from the patient's head for eyelashes and eyebrows and covered it with silicone to make it a little more lifelike. Of course, that's him. He uses these glasses because these are prosthetic eyes. But at least cosmetically it's certainly better, and it protects that hole from getting dirty. My last message to the pathologist, clearly to you too, is important to the pathologist to commit him or herself when broad, hyposeptated, ribbon-like or irregular hyphae are seen either on a frozen section or a smear in the wet lab, because voriconazole, which we've used for the last 3 years like water in this country, is pretty much ineffective with most of the mucorales. So at least until 1 or 2 years ago, it was indispensable for Dr. Green to know this, so he would not go to Vfend and go to Ampho-B or to the new drug, which at one point, a year and a half ago, posaconazole was still on a compassionate basis, and it then became FDA approved, and I'm sure now he's going straight to posaconazole. So I don't know in vitro studies whether POSA is very effective with the mucorales. Jose, do you know? I'm sure it is.
We do use it.
I'm sure it is, but for how long? That's the question. And for how long?
That's the question.
So it may well be that we may not be able to use it, and then go back to amphotericol, which at least there's those lipid formulations that Dr. Green uses so effectively, and so be it. In the interest of time, that's all I can give you. I hope I haven't overwhelmed you. I'd be glad to help you in any way during your training, like I do with the path residents. I'm very, very, very approachable. God bless you. I'm glad to meet you, and we'll meet more in the future. Okay, thank you much.